Good morning, everyone. Welcome to the 2021 webinar week on public-private partnerships to counter drug challenges organized by the U.S. Department of State, Bureau of International Narcotics and Law Enforcement Affairs. We will start in just a minute to give participants a few more moments to join this morning. I would like to mention that we have interpretation today between English and Spanish. You can select your preferred language with the interpretation option at the bottom. En español, tenemos interpretación hoy. Pueden seleccionar su idioma preferido con la opción interpretación. All right, welcome once again, everyone. Good morning, good afternoon, good evening, wherever you may be joining us from. I see the participant numbers climbing rapidly, but with a large majority here. So I believe we can get going. So once again, welcome to the 2021 webinar week on public-private partnerships to counter drug challenges organized by the U.S. Department of State's Bureau of International Narcotics and Law Enforcement Affairs. Today's session is part of a week-long series of interactive webinars in which we will showcase how government and business can work together to address distinct aspects of the world drug problem through case studies and sharing of best practices. Today's topic is on quality assurance in treatment. We would like to thank OAS CCAD for providing technical support and simultaneous interpretation into Spanish for these webinars. En español, tenemos interpretación hoy. Pueden seleccionar su idioma preferido con la opción interpretación. These sessions are being recorded and will be available online along with a comprehensive list of recommendations and resources that will be posted to our website at the end of the week. For any members of the press, please note that these sessions are off the record. And finally, there will be an opportunity for question and answer at the end of this session. Audience members, you may submit any questions via the question and answer button at the bottom of your screen or by using the raise hand function. And I know there's both a chat feature and a question and answer feature. And we'd request that you use the question and answer box for any questions to ensure that the panelists are able to find them readily. So now we can go ahead and start today's program. We are thrilled to be joined this morning by Tom Hill, who currently serves as a political appointee in the Biden-Harris administration as Senior Policy Advisor at the White House Office of National Drug Control Policy. Prior to his appointment, he worked at the National Council for Behavioral Health as both Vice President of Practice Improvement and as Senior Advisor on Addiction and Recovery. Tom also served as a political appointee in the Obama administration at the Substance Abuse and Mental Health Services Administration. He brings with him today a wealth of experience and knowledge on demand reduction initiatives and has graciously offered to share with us some opening remarks. So Tom, without further ado, the floor is yours. Thank you.
Thank you, Alan, for the introduction. And thanks to the Department of State and the Bureau of International Narcotics and Law Enforcement Affairs for hosting Webinar Week. So I'd also just like to thank the panelists who will be soon presenting their work and to all the people who are joining us today. This week is focused on strengthening collaboration between private sector and governments across the globe in addressing significant drug challenges that we are all facing. From preventing the diversion of precursor chemicals to building recovery-ready workplaces and stopping the flow of drugs on the internet, we all have a role to play in reducing the supply of illicit substances in our countries, as well as ensuring that collective public health efforts are driven by the latest research and evidence. Today, I will talk about the United States' domestic efforts to expand access to quality, evidence-based treatment, and how we can all work to improve quality around the world, including by leveraging public-private partnerships. As you've no doubt heard from other speakers this week, addiction and the overdose epidemic are significant challenges here in the United States. The Centers for Disease Control and Prevention estimate that we lost 93,000 Americans to overdose deaths in 2020. And why is this? Well, there's a number of reasons for it, but we've got two at the top of the list. The first is the increased lethality of the drug supply, especially with fentanyl-related substances. And the second is the lack of a robust addiction infrastructure to make sure that everybody who has a substance use disorder can access the treatment they need. For example, the CDC predicts that nearly 62% of US overdose deaths in 2020 involved synthetic opioids other than methadone, and that synthetic opioid category includes fentanyl. So meanwhile, just 12% of the more than 21 million Americans that are aged 12 years and older who needed substance use treatment in 2019 received it. 12%. While most people who needed treatment did not seek it, this speaks to the lack of sufficient infrastructure to help identify people with substance use disorder and connect them with evidence-based treatment. Today's session will focus on this, and particularly on how we advance evidence-based treatment and increase effectiveness through quality assurance, regardless of whether a person receives treatment from a nonprofit, a government, or a private sector treatment provider. Domestically, President Biden has made it clear that addressing the overdose epidemic and substance use disorder is an urgent priority. In April, the Office of National Drug Control Policy, ONDCP, released the administration's first-year drug policy priorities, which focus on building a stronger, evidence-based infrastructure to meet these needs. The Biden-Harris administration's domestic public health approach to the issue spans a continuum of care, from evidence-based prevention to harm reduction, treatment, and recovery support services. On the treatment side, we're working hard to reduce obstacles to evidence-based treatment so it's easier to access. We are reviewing policies recommending ways to modernize methadone treatment for opioid use disorder. We've made it easier for patients to access medications for opioid use disorder, which is the standard of care, by allowing medical practitioners to prescribe buprenorphine to more patients. We are exploring making permanent the COVID-19 emergency provisions regarding beginning medication for opioid use disorder by telehealth and allowing take-home methadone. As evidence shows, these policies have been effective. And we know that incarcerated individuals re-entering society are among the most vulnerable to overdose. So we're working to expand access to evidence-based treatment in correctional settings. In terms of credentialing, the Biden-Harris administration is actively working to increase the number of certified community behavioral health clinics, that's CCBHCs, which provide person-centered and family-centered integrated services, including 24/7 crisis interventions for individuals with serious mental illnesses or substance use disorders. As you know, government can't do everything on its own. We need to work in public-private partnerships to improve quality. A number of groups in the United States are pioneering ways to improve quality. The National Council for Mental Well-Being, for example, is working on a technical assistance and quality assurance at our CCBHCs. Meanwhile, Shatterproof is working on initiatives related to treatment for substance use disorder, especially reducing the stigma surrounding it. So Shatterproof was founded by a parent of somebody who died from a drug overdose And they've been working hard to break the stigma that too often prevents people from accessing the treatment they need. Stigma has prevented a lot of this work from progressing and proves why quality assurance and establishing best practices are so important. And this includes providing fast access to treatment so people can access it when they're ready, creating personalized evaluation and treatment plans because we all know that one size does not fit all, ensuring that medications for opioid or alcohol use disorders are widely available, offering effective behavioral therapies for addiction that are known to be effective, such as cognitive behavioral therapy and family behavioral therapy, and addressing other factors that can affect treatment and recovery, including housing, employment, personal relationships, and so much more. This is a vital part of building and strengthening our addiction infrastructure. The United States is working to lead on evidence-based quality care, and we are making progress. However, we aren't the only country facing this problem, and we aren't the only ones working to solve it. So in the global situation, according to UNODC, 275 million people worldwide used drugs in 2019, and more than 36 million had a substance use disorder. Meanwhile, only 1 in 8 people worldwide with a drug use disorder receive treatment each year. So the US is bringing everyone together to find a way for us to all expand access to treatment and make sure that the treatment that is offered is effective. And quality assurance and credentialing are important parts of this. That's why the United States has worked closely with international partners to develop and support capacity building and training activities in over 60 countries to improve drug prevention, treatment, and recovery services for people with substance use disorders. We've developed networks to connect academia, policymakers, and practitioners in both the nonprofit and private sectors to share best practices and the latest research. And public-private partnerships can help us achieve even more. We have a great panel with us here today, and they will highlight new tools and programs available to advance quality at a systems level, including training for health and regulatory officials in participating countries to identify opportunities for quality improvement within their national treatment system. And they will discuss ways in which national governments, treatment centers, and quality assurance agencies can join this effort, recognizing that treatment systems worldwide could include private, public, and nonprofit options. I also want to say that our work, the work our panelists and partners are doing, especially the effort by the World Health Organization and UNODC to develop and promote the international standards of treatment for drug use disorders, is incredibly important. It lays the groundwork for this next level, which is a systems-wide approach to improving and standardizing the services that are provided and from which we can all benefit. And UNODC's program on quality assurance and the work they do to support substance use treatment practitioners around the globe will make a real difference in people's lives. In closing, the United States fully supports expanding access to evidence-based quality treatment around the world. This is how we can help people reach and maintain recovery and contribute to society in a meaningful way, and we all have a role to play. We have brought everyone together this week to try to identify the gaps and make sure that we have the best approach to this. As President Biden recently said, addiction is personal to millions of families. It is personal to my family, and I know that there's hope. Treatment works, recovery is possible, and my administration is here to support every person and every family on their journey to recovery. So thank you all for your work to this end, and enjoy the webinar. I think we'll all learn a great deal. Thank you so much.
Tom, thank you very much for your opening remarks and for first sharing the US domestic experience, but also how we can all work together to improve access to treatment and improve, as you described, the infrastructure of treatment. Your remarks provided, I think, the perfect framing and opening for the panel. So I would now like to invite Anya Boos, Program Officer from the Prevention, Treatment, and Rehabilitation section at the UN Office on Drugs and Crime, to share a presentation. Anya has worked for more than 16 years in the Prevention, Treatment, and Rehabilitation section of UNODC and manages UNODC's global project on the treatment of drug use disorders. She will be sharing today more information on the international standards of treatment and UNODC's work on quality assurance. Thank you, Anya. Over to you.
Thank you so much, Alan, and really thanks very much for INL and the State Department for having us here. And for all the participants out there on the screens, also thanks for these excellent introduction remarks to ONDCP and for the nice words in our direction. So let me speak to you a bit about what has already been hinted at, our work on quality and treatment in line with the UNODC WHO international standards for the treatment of drug use disorders, which were launched in 2020. So for those of you on the screens out there who maybe don't know what's UNODC, so we're basically part of the Secretariat of the United Nations, and we are operating in more than 150 countries all around the world where we have bigger or smaller offices. Drug use disorders, to set the base for the discussion, has been recognized as a biopsychosocial health disorder, both by science, and it's also classified in the International Classification of Diseases, and it has been recognized as a health disorder also by very high-level policy documents like the General Assembly outcome document on drugs 2016. We also know that prevention and treatment of drug use are part of the international development agenda. So offering that is seen as part of advancing the development of countries in this world. Then, in addition, member states to the United Nations or the parties to the International Drug Control Conventions have taken a commitment to provide services for people with drug use disorders on a continuum of care, as you can see here. The global situation with regard to drug use and drug use disorders was already mentioned. So we have more than 35 million people globally who suffer from drug dependence and would be in need of treatment. And the global kind of population currently estimated having used an internationally controlled substance at least once in the past year is 275 million. On the right side of the screen, those see kind of some projections that were made by the UNODC research section, where in some regions, like for the African continent, mainly associated with population growth, there might be very soon a very big increase in the number of people who use drugs. So urgent interventions and availability of services is also needed with a view to these projections. But what we know in reality is that the treatment gap, so how if 8 people are in need of drug dependence, at the moment only 1 has access to it. A few years ago, when I started working at UNODC, we were at 1 in 6, then we were at 1 in 7, now we are at 1 in 8. So this kind of treatment gap is not getting better globally, it's getting worse, which obviously has to do with population growth. But there is work that needs to be done, because if you see the picture here of Maggie, we know what untreated and not having access to drug use disorder treatment can look like. Also, having talked about accessibility, the quality of available treatment for drug use disorders is often low. So interventions could be well meant, but not based on evidence, or sometimes interventions are also kind of punitive from the onset on, and they could be ineffective or harmful. And what we want to see are interventions that can reduce symptoms, that improve kind of social functioning, improve health, and decrease the risk for negative health and social consequences of drug use. What definitely needs to stop, as said, and what's unacceptable but still happening, are human rights abuses in the name of drug treatment. And that was one of the driving forces, so to say, to set up international standards so we can say what is treatment and what is not treatment. This kind of need for standards has been recognized in 2009 by the Commission on Narcotic Drugs of the United Nations, that has called kind of for the development and adoption of appropriate healthcare standards for demand reduction, so for prevention and treatment. In the same year, in 2009, UNODC and WHO, we formed a global program on drug dependence treatment and care together. And in the framework of this program, a few years later, we started on the development of the international standards for the treatment of drug use disorders, which were first launched as a draft for field testing in 2016. This draft for field testing already made quite an impact because it was immediately recognized in a resolution of the Commission on Narcotic Drugs, which then asked member states to use kind of the standards developed by UNODC and WHO, and requested UNODC, WHO, and other stakeholders to develop initiatives to disseminate the international standards. In the same year, this was an important year for international drug policy. Also, the General Assembly of the United Nations had a special session on drugs, and in the outcome document asked for the promotion and implementation of the standards on treatment of drug use disorders developed by UNODC and WHO to provide guidance, assistance, and trainings, and to develop standards and accreditation for services at the domestic level. So the draft for field testing of the standards then went into extensive field testing, actually, with over 1,200 health professionals that participated in it. And in 2020, we could launch the final version, the revised edition of the international standards, which is now available in a few languages already. I think we have translations up to 5 languages by now. The standards are really there to assist and support member states in the development and expansion of drug use disorder treatment services and systems. So it's important that this is at both levels, which are evidence-based, effective, and ethical. And the guidance in there is based on existing WHO guidelines, UNODC guidance documents that existed already. So in this year, we had, again, so to say, a policy boost to the international standards when the Commission on Narcotic Drugs again passed a resolution in which it encouraged member states to continue developing treatment services that are in line with the international standards for treatment of drug use disorders. So the policy support globally is really there. We just have to get to action, right? The international standards are guided by 7 principles. I just mentioned a few of them here. The treatment must be available, accessible. We talked about also attractive. Maybe think about what that could mean. And appropriate needs to be in line with ethical standards, evidence-based. There has to be coordination with the justice system. We need to think of groups with special clinical needs. There has to be good clinical governance or management of treatment services, and the services need to be integrated in an overall approach. This slide very much summarizes the elements, what you can find in the treatment standards, but obviously I encourage you to read yourself. So they provide kind of a continuum of care, how treatment can be offered in different settings, from, let's say, more community settings like community-based outreach or screening and non-specialized healthcare settings, and then to specialized outpatient treatment services. Sometimes specialized short-term inpatient treatment is needed, and some people might need specialized longer-term inpatient or residential treatment. And the interventions that are listed are all evidence-based interventions backed up by guidance from WHO, kind of around psychosocial treatment, pharmacological treatment, and related areas. So this slide, I just wanted to show you for a moment. That's really a little bit, maybe you know these children books that are like in a similar style, right? Where you can always ask, do you see kind of the outpatient treatment service? Does anybody see the police kind of helping somebody who maybe has just overdosed? Do you see people at a drop-in center that are being offered some possibility to do their laundry? Do you see people receiving their medication? Maybe do you see the counseling for a woman, maybe with drug use disorders, who just had a baby? Do you see the peer support? I mean, so this picture really kind of shows all the elements at work that we hope kind of a good treatment system and good services could offer on this continuum of care that I've just described. So the evidence-based psychosocial interventions that are especially mentioned in the standards and very similar to what was just mentioned by ONDCP are kind of evidence-based interventions such as cognitive behavioral therapy, also contingency management, which we really would hope would get more pickup in real-world community settings, motivational interviewing, family-oriented approaches, but also not to forget kind of mutual help and recovery support. And in terms of pharmacological treatment, and again, I heard a lot kind of already in the introduction from ONDCP colleagues. So of course, withdrawal management needs to be offered by substance for those that need. For opioid dependence treatment, we have a range of medications for maintenance treatment, including methadone, buprenorphine. There's also opioid antagonist treatment with naltrexone. For stimulant or cannabis use disorders, we in reality only have symptomatic medications. And for opioid overdose, again, so there we do have a medication, naloxone, and also thanks to the support of the State Department, which just could demonstrate in a very large study that community management of opioid overdose with naloxone can also be implemented in low-middle income country circumstances. So this again, kind of a slide on the treatment systems. I've mentioned a little bit before, we just have to really match the intervention to the need of the person, not one size fits all, like for no other disease. We would also not send everybody for a heart surgery who maybe feels a little bit of chest pain. So the intervention really needs to be well matched here. And in this public health principle that the treatment in the treatment system, we need to offer the most effective, least invasive and lowest cost drug treatment intervention first in a continuum of care, right? And with that in mind, we think in a well-developed system, the majority of services can be offered at outpatient level. So as we did the field testing for the standards, one of the things came out that, you know, people said the standards are very high utility, high appropriateness, high comprehensiveness. And in terms of feasibility, you know, that was also relatively good rating, but the people also said there would be a need for additional support to facilitate the implementation of the treatment standards. And we hope that the quality assurance and quality appraisal tools that we've been developing since then with a group of international experts can help with that. So this kind of group that we met with since 2016 reviewed existing standards, looked at what different regions have, looked at the treatment standards, of course, and Annette, who will speak next, kind of helped us a lot with that. So we developed kind of two quality assurance tools, one for treatment systems and one for treatment services, which we are using already in a lot of trainings, but we have not really published yet, even though we are already using them. But what will be published tomorrow, and I say more about that, is kind of a very new document that has been now agreed by many international and regional agencies on quality assurance and quality appraisal, the so-called key quality standards for service appraisal. And those of you who have worked with us on this can imagine how happy I am that we have the final title for this document. Kind of in terms of quality assurance processes, and I know Louise will speak more about mapping of treatment services, just to say that of course it's very important and not every country has a good overview to understand in the public, in the private, in the civil society, who is providing treatment, what kind of resources are available. And in some countries, it's really, really useful to make a mapping, a directory of services, but I understand also what are the resources available in different settings. For that, we can offer the UNODC WHO facility survey, and there are similar tools available. The quality assurance services assessment, Annette will speak about more now and about the scoring, but in principle, what has been developed are some core standards or core criteria. So those every treatment service should have, and some optional that need to be kind of implemented or can be appraised, reviewed as applicable, right? Because an inpatient service has maybe a different vision or mission and different services available than a community-based outreach service. So the optional kind of standards are adjustable, but the core standards, which include, for example, patient rights, are in a way non-negotiable, right? So every treatment center should be ready to measure themselves by those. Then in terms of the systems appraisal, so those goes very much kind of in line with the treatment service pyramid, right? So how have we organized our treatment system in the country? What interventions do we have available and what level, and where do we allocate our resources? Questions like that. Do we offer one-stop shop services? Do we work with networks of services? And these are kind of examples what the kind of appraisals for services and systems can look like. So kind of this, which looks more like an Excel table, could be like the scoring sheet from a treatment service or even at the country level. So where you can see with this kind of traffic light system that I think Annette will explain in more detail, which areas kind of a treatment service is performing already quite well, which areas might need development, and the red really needs attention. And then here on the other side, you see this is from an example how real world treatment systems are sometimes looking very different from the ideal pyramid that we had presented there. So this just as an example how this works when we work with countries, right? And this is also kind of adjusted example from a country. So when the quality assurance circle takes place there, right? So this kind of scoring maybe has been done, and then UNODC would work together with the host government and see kind of how we can work establishing an kind of sustainable appraiser team, how quality assurance mechanisms can be on a continued basis be included in national policies and strategies, and how quality assurance committees can be set up. And then in terms of UNODC technical support, we have, for example, offered follow-up capacity building, development of protocols or policies together, standard operating procedures. And what we also do together with the country is joint fundraising. These are kind of an overview of the countries where we have worked so far with the quality assurance work in the framework of our joint programs. Many of these countries will present tomorrow in a member state briefing that I'll say a few words about. Just also have a look at these two figures at the end there. This one looks like my former boss, Gilberto Gera, and it says kind of, you did a great job, show me how you made it. And I think what we want to send is a message that quality appraisal needs to be done in a participatory way. It's not kind of to lock down treatment services and say you are no good. Sometimes that maybe is necessary, but the idea is really to work in a partnership and improve together what is there so that we jointly can close the treatment gap and offer treatment services that are accessible and of quality. So I mentioned already a few times, and those of you that are actual government or member state representatives, if you don't know about this yet, please let me know right afterwards. Get in contact with my section at UNODC tomorrow and on Friday, Thursday and Friday. There will be a member state briefing fully online on quality drug use disorder treatment. We will launch a new initiative, and this new quality assurance tool will be launched, and also a consortium of quality assurance agencies will be launched by our partners from the Colombo Plan. And also this document that I referred to, the key quality standards for service appraisal, will be launched together with many regional and international organizations, including some that are present here with us today. Just the last slide, kind of as we were talking about public-private partnerships also today, just to say that we at UNODC, we're working a lot with our civil society partners. There is the Vienna NGO committee and NGOs that are working there and offering services, kind of describe what they have on the NGO marketplace. We used to have our TreatNet network, and Nancy Paul, who's here with us, is very much part of our TreatNet network of treatment centers kind of coming together. So our work with non-profit civil society partners, very easy, we have a lot. With for-profit partners, for us at the UN, it gets a bit more complex, but just to say there is a United Nations Global Compact through which, and through due process, so to say, we can also kind of reach out and work together with private organizations or private companies. So with that, I hope let's work together with all of you there. The interest is amazing to scale up evidence-based, rights-based quality drug treatment. Let's close the treatment gap. Let's support people and families affected by drug use and drug use disorders all around the world. Thank you very, very much. I leave here my contact details just for a moment. So as said, especially if you're a member state representative and you have not heard about our member state briefing on Thursday and Friday this week, please contact us on any of those contact numbers here. Thank you very much for your attention. And again, thanks very, very much for the US INL, who's really our main supporter in all the work we do all around the world, including on quality assurance. So thanks very much also for that continued trust and support. Thank you.
Anya, thank you very much for your presentation and for sharing with us really the foundational documents that have been created by UNODC and in collaboration with WHO and many others, and for walking us through how the international standards have created the foundation, but how UNODC has used those documents to create some concrete programs, which, as you mentioned, will be launched tomorrow. With that foundational and historical background and framing that Anya provided us, our next presenter, Annette, will discuss in detail the quality assurance programming that Anya referenced. Annette has spent 35 years working in drug demand reduction and has worked as a practitioner, a research fellow for the University of London, and as strategic director of the National Health System Addiction and Offender Healthcare Services in London. She has held national posts as head of policy for a national NGO in the UK and director of quality for the National Treatment Agency on Substance Misuse in England. For the past 5 years, she has been the lead consultant for UNODC and WHO, working on quality assurance, and has worked in 15 countries to provide training and capacity building. So Annette, we now turn to you to learn more about the quality assurance tools. Thank you.
Thank you so much, Alan, and thank you to INL for giving the platform and for their continued support on a topic very dear to my heart, which is quality and quality assurance in drug use disorder treatment or drug treatment. And Anya, thank you so much for that fabulous overview of all of the wonderful international work that's been happening in relation to this. It's really important. So today I'd like to briefly cover what is quality and what is quality assurance, with a particular focus on drug treatment or drug use disorder treatment, and look at some of the foundations of quality assurance, including this very important public-private partnership. We'll take a little bit of a look at how quality assurance works, and I'm going to ask you guys to do some work out there in terms of doing some scoring or ratings of standards. So I want you to use the chat function, which I can see in the corner of my screen when we do this. So I want you to answer some questions, if you will. And I want you to think about things like implementing quality assurance in services. What happens if you find a never event or an event that you really don't want to happen in drug treatment? We'll talk a little bit about improvement planning and then how you can support quality assurance in drug treatment going forwards. Now, I think that some of you may not realize that you have experience generally in terms of quality assurance, but quality and quality assurance is something that impacts on all of us in our daily lives. By quality, I mean something that is of a known standard or degree of excellence. And as we go about our daily lives, we may see all kinds of quality assurance marks or trademarks or kite marks. And we'll think about quality when we're generally looking at products or purchasing products or services in our daily lives, whether that's food, whether that's organizations that we might interface with. And there's a couple of examples there on the screen. So I found a quality mark that certifies that a certain type of food is halal, or food maybe, we see this one on chocolate in the UK, so this is why I know it. We see this fair trade mark, which is about ensuring that the people producing the food products or goods are getting a good wage, and there's good kind of quality of interaction with the supplier there. For organizations, you may see kite marks in terms of things like carbon neutral organizations, again timely given the big conference on climate change that's coming up, and there may be some that are specific to drug use disorder treatment, such as the other two that are there. So you will know more about quality assurance in your daily lives than you think. But what about quality in drug use disorder treatment? Okay, so the World Health Organization has a nice definition of quality in respect to treatment. And they say that quality is the extent to which health services provided to individuals and populations improves desired health outcomes. So the focus there is very much on the patient and patient outcomes. And they say there that treatment must be safe, effective, timely, efficient, equitable, and people-centered. And many systems come up with these type of classifications or words. Now, Anya talked about this extremely important document. So I think for the first time ever internationally, we've got international agreement on what is scientifically evidence-based practice in line with human rights. And this is an excellent foundation stone for quality assurance and quality improvement. And you also talked about us having UNODC standards and toolkits to help improve quality. And this stands on the shoulders of other work as well. So this work's also been done by other organizations, such as in Latin America and the Caribbean. There's a project called with COPPERLAD and CCAD that looked at this as well. Now, in terms of public sector and private sector involvement in drug treatment, I think this is really widespread, so that whether it's a drug treatment service, whether it's a quality assurance organization or a certification organization or an accreditation agency, we have a range globally as to whether or not these organizations are run by the government or run by a state, whether they're non-government organizations, whether they're charitable or not-for-profit organizations, or whether they're private sector. And the reality is that everybody's got a role to play. And if we really want to expand drug use disorder treatment to meet these international targets, then we need everybody to play a part, and we need to work together to do this. Okay, so let's take a little look at how quality assurance works in treatment. Now, essentially, what we're trying to do is embed in treatment services a cycle of continuous improvement, a process of continuous improvement. So this is not a one-off thing. And this is an excellent embedding international standards. So we want a treatment service to identify what standards apply, then embed the quality assurance mechanism. So that will involve collecting data or evidence against a standard, comparing their practice to standards. If they fall short of a standard, then planning improvement to meet the standard, implementing those changes to improve, and then down the line, monitoring or re-auditing themselves to see if they're reaching the standard, and then starting that whole process again. So it really is about the scrutiny of a service against standards or benchmarks. Now, sometimes this is done internally, but ideally this is done externally or independently by an independent audit or inspection. And it really is about trying to embed this culture of continuous improvement in services and systems. So this is what we're trying to do. So some of the evidence that a service might gather to compare itself to a standard, or the evidence that might be gathered by a quality assurance agency, such as an accreditation body or a registration body, are the services documents. So the vast variety of documents that a service may have. So descriptions of what it does, annual reports, etc. They may interview the managers. Very, very importantly, good quality assurance mechanisms gather patient or service user feedback. And indeed, in terms of the UNODC quality assurance mechanism, patient feedback is critical, right? It's a must-have. Routine service data can be very important, such as how many people complete treatment, what kind of complaints are made about the treatment, etc. Looking at patient records or case notes and auditing those are very important, making sure that the right governance to enable you to look at that is in place. Medicines management audit, staff record audits, or talking staff, and importantly, walking around the services. And I'm sure that some of our later speakers, Dr. Awal Salihu and Nancy will talk about this in more detail. But basically, there's a variety of evidence that you can use to judge whether a standard is being met. And once you've got that kind of evidence, then what happens is a service will be scored on a standard. And there's lots of different ways to do this. So a service may be scored and given a number as to whether they meet, partially meet, or don't meet a standard. They may be given a BRAG rating, where BRAG stands for blue, red, amber, and green. Where blue would be a standard is not applicable. Red is a standard may not be met. Amber is a standard is partially met. And green is a standard may be met. Remember this, because I'm going to ask you to use this in a minute. It's also important to stay for using colours. We should also write the words, because we do have a percentage of the population that are colourblind. Then we need to be accessible to people with a range of abilities. Or certain standards might get a percentage rating. And indeed, some standards rating systems use a narrative, or they use words to describe whether a standard is met. So what do results look like? On the right-hand side, we've got an example here of a scorecard. So we've got standards down the vertical axis and services across the top axis. And you can see whether a service is meeting a standard. And indeed, if you're looking at a local area, you may be able to identify, therefore, whether there are deficiencies or strengths in a whole system. So if you've got all services scoring green, the system is strong on that. Or if you've got all services scoring red or red amber in a system, that might be a systems issue that you can address. In my country, I'm in the UK, we have a body, an external body called the Care Quality Commission that is responsible for the inspection of all health and social care services. And we get rated as outstanding, green star, good, green, requires improvement, amber, or red, inadequate on 5 areas, whether a service is safe, effective, caring, responsive, or well led. And in my country, those results are published on the internet for everybody to see. And speaking as an ex-service provider, that certainly keeps you with an eye on quality. One of the things I want to talk to you about is gaining agreement on what the threshold is for scoring can be surprisingly difficult. And it's really important that when you're implementing quality assurance, a country may need to culturally adapt standards to fit their circumstances, and also adapt or bench the scoring to match their circumstances, whilst staying true to quality. And getting agreement on that may be quite difficult initially. And I want us to have a quick look at this. And I want you to really think about this question and maybe put some answers in the chat here. So imagine that you are a service assessor. And imagine that you're going into a treatment service and you're looking at the standard. Do the patients have an individual treatment plan? So the standard is all patients should have an individual treatment plan. And you've gone into a service and the service has audited the patient records to look at whether or not the patients did indeed have individual treatment plans. And what the findings were that 75%, 3/4 of patient records were found to have a treatment plan. What do you think that means? Do you think the service meets the standard? Is it green? Does it partially meet the standard? Is it amber? Or does it not meet the standard? Is it red? It's worth saying that all patients in specialised drug treatment are entitled to a treatment plan based upon an assessment of their needs, and that takes into account their personal choices, like any patient in any health condition. Okay, and I can see in the chat we've got a lot of ambers coming through here. A lot of ambers coming through. Very, very interesting. Let's have a look at what happened when we did this exercise during a UNODC training. This was done in 2019. And I'm showing you here the results from UNODC training in Indonesia and then also in Central Asia. And they were agreeing with what you're putting in chat, in fact. So the standard is this one here where the arrow is. So all of the 4 groups in Indonesia mark this as an amber. And in terms of the Central Asian countries, all of the countries either marked this standard as amber or amber red. So partially met or partially met to not met. So you're in agreement with this. So you're thinking correctly along the right lines. Okay, what happens if you're doing quality assurance and you find a never event, something that doesn't happen, that shouldn't ever happen, or indeed a potential abuse of human rights? Now, I have to say, as a service provider, never events sometimes do happen. I've had instances where, despite us checking toilets regularly, we've had service users overdose in the toilet. It should never happen. It has occasionally happened, and you have to look at that and look at how you can stop that happening in the future. In terms of setting up a quality assurance mechanism, that mechanism needs to think about this in advance. And when a service signs up to a quality assurance mechanism, this should include agreement about what should happen if a never event is found. Okay, so here's an example. You are a quality assurance assessor. You have been inspecting a drug treatment service, a residential rehabilitation unit, and you're going around and you're interviewing service users, and you find out that some service users did not consent to treatment and are there against their will. Now, this is against UNODC and WHO standards. What do you think about this situation? Okay, what would you do in this situation? Think about that one. And then in later presentations, we'll have some examples of some of the things that's happened in these circumstances. Okay, almost there. So what happens when a service rating is actually agreed? Okay, now the first thing to say is it's normal for services to get a variety of ratings on standards. So getting green all the time is not realistic. When I was a service provider, I didn't get green all the time. Sometimes quality slipped. For example, if you lost key members of staff, or your staff changed, or you were having to implement something new. So quality does vary over time, and that's why it's so important to keep doing the quality assurance cycle. So what might happen is that if a service meets standards, they may get an accreditation or certification that they're meeting the standards. Where standards have not been met, improvement is required. And therefore the service may need to develop an improvement plan and implement evidence-based methods to explore what's causing the problem, because it may not always be obvious, and then take action to improve. So if a standard's not met, explore why that's not met, take action to improve, and then re-audit. Okay, I think my time is up. So my concluding remarks are: assuring the quality of drug treatment is really, really important. This group of patients or service users face more stigma and discrimination than many, many other groups. Public-private partnerships are important in quality assurance because we have public and private organisations and agencies involved in both the provision of treatment and the quality assurance of treatment. And if we're going to expand treatment and get that quality improvement in place, we need public and private organisations involved. So please support initiatives to benchmark and assure quality and promote equivalence of healthcare for this patient group. And also, please promote international initiatives, including the international standards that Anya so eloquently spoke about, and a new forthcoming international consortium on quality in drug use disorder treatment. So thank you very much for your time, and thank you for responding to chat. Thank you, Alan.
Thank you, Annette. Thank you for the very interactive presentation as well, and for walking us through the concrete way in which the quality assurance program is structured. So we will now turn to Dr. Awal Salihu, who is a consultant psychiatrist and lecturer at the Aminu Kano Teaching Hospital at Bayero University in Kano, Nigeria. He has worked in treatment and rehabilitation for the past 15 years and is also the UNODC focal point for treatment at the Aminu Kano Teaching Hospital. He was the team lead for the Nigeria Quality Assurance Standard pilot that Annette just referenced. Now, just before I turn to Dr. Salihu for his presentation, I would note that we have about 35 minutes left in our scheduled time and 3 more presentations. So I would ask our next 3 presenters to please try to conduct your presentations in about 10 minutes. So we have just a few minutes remaining at the end to answer the questions that I see coming through. So with that, Dr. Salihu, over to you.
Dr. Salihu, you are muted.
Thank you. Thank you, Alan, for the introduction. Before I actually start with the notes and the lesson we learned in Nigeria, I would like to put some little background. It all started with the United Nations Office on Drug and Crime in Nigeria office, the EU, under its EU-funded project and other important development partners supporting the Nigeria's Federal Ministry of Health back in 2016. In 2016, minimum standard for the treatment of drug use disorders was developed. And in 2018, is followed by treatment guidelines for the drug use disorders in Nigeria. And by 2019, efforts to develop quality assurance assessment tool commences. A team was formed. You can see the members of the team on this slide. These teams include members of the model treatment centers in Nigeria, then some members of the UNODC office, and then representative from Federal Ministry of Health, under the guidance of the consultant and expert on quality assurance issues, ANET. Here, the team received training on service assessment, standard scoring, working with providers on quality improvement processes. Okay, this is the timeline on how the processes were done from the workshop, the first workshop of the development of quality assessment instrument, down to these pilots and then other activities after. Actually, the tool consists of culturally adapted international quality standards here on the screen. And it has 20 standards and 44 criteria. When the tool became ready for pilot testing, Kano State was selected, one of the states from the 36 states of Nigeria, for the following reasons. It has good drug treatment services and, of course, for some FOA services as well. And it was a state which is more typical of Nigeria. It's cosmopolitan. So it has a large population of about 14 million. And it has the biodiversity that Nigeria is characteristically has. And the state had number of state-run services that had attracted negative media attention in previous years. For those who really watch BBC, they must have seen something of your title, Sweet Coding. If you Google it on YouTube, you will have that video after now. And Kano State had experts in addiction treatment, which include myself. And then Aminu Kano Teaching Hospital has 2 members of the QA expert in the QA expert group for the country. And we have connection with the state health system. Here is, if you look at this map of Kano State, the stars here give an information about the spread of the selected facilities for the piloting. As at the time of the piloting, there is no private drug treatment center that offers Oxidose treatment. So all these centers that are involved in the piloting are public facilities. The actual quality assurance pilot method, most of what Annette has explained with those steps. We had a formal agreement which we obtained to conduct pilots from service management and the state, and then we also obtained consent from the actual managers of the facilities. When we arrived at the facilities, we used like 48 hours to actually conduct the pilots in the 13 and the 15 facilities. We divided ourselves into teams, and then we visited at least 2 centers per each team. And the processes involve interviewing the service manager, interviewing patients, all trying to assess managing how the facilities is managed, and then finding the patient perspectives about the services and so on. And then we walk around to see the facility ourselves, and then we check the case note audits, and then we request a services document and talk with the staff. All these things that are included in the quality standard we're supposed to assess the facilities for. The findings on the QA pilots includes with the exceptions, all the centers are not specialist drug treatment services, with the exceptions of 3 centers, which include American Teaching Hospitals, are specialized drug treatment services. And at the end of the pilots, these facilities obtain variable scores based on the scoring system Annette just shown. We use the 3 points, the 3-point score, and then we use the RAG system. And some obtain good scores, and in some items they score very poorly. There was some of the interesting findings that needs a quick improvement include there was widespread use of strain using chains and stocks in some of the facilities, and there was alleged cases of sexual abuse, in particular in one of the female-only centers in the States. And then many of the services were extremely dirty and unhygienic, and there's lack of mental health treatment for clients with mental health problems. Most of the non-specialized centers, most of the clients there have either comorbid mental health problem with the substance use problems, or some of them are just purely mental health cases. And then with this, where medication is provided for the mentally ill in those centers, in most places is offered by unqualified staff. With these findings, there is need for rapid action that should follow this. And then what we did was to escalate issues with service management, the State Emergency Management Agency, Health Service Management Board, UNODC, and we had carried out advocacy and briefings to these bodies, in particular, the senior members of the State Emergency Management Agency and Health Service Management Board. One of the requests, the most important request that we put there is we request immediate actions and assistance to stop abuse and improve practices in those centers. And there was good response from SEMA and Kano State Health Service Management Board. In particular, the case of sexual abuse was SEMA investigated the case of sexual abuse, and they have also told us that a punitive measure has already been taken on the persons who perpetrated that crime. And the follow-up is to make sure that that kind of event has not happened before, shall not happen again. Other follow-up actions include two-day sensitization training that was held for the quality assurance pilot sites managers. Those sites were supported to develop improvement plan with assistance of the QA team and training for the managers and the staff on mental health issues and substance use disorder prevention and treatment was undertaken. Working with Health Service Management Board and Kano State Medical Lead, myself, my humble self, we provided an ongoing mental health outreach, which Amini Teaching Hospital liaises with state emergency management agencies to at least pay visits to some of the centers and be able to help the staff there evaluate cases and recommend some interventions. One other important thing we think shall happen is rolling out of the QA mechanism in other states of Nigeria. Now, with the advent of the pandemic, the COVID-19 pandemic, if not for that, by now, so many parts of the country should have had the QA mechanism rolls out. But with things easing out in Nigeria, this will take place very soon. We think the QA, the quality assurance assessment, is very important due to the following reasons. One is quality assurance can be very practices, as I have mentioned in our findings, and piloting can be done very quickly, but one have to have good team with good attitude and the right investment be made. And then the federal and state health involvement or whatever system of governance in a place you operate, a liaison between the top and the bottom is very critical for this quality assurance assessment to work very well. And quality assurance can improve treatment for the patients and can also improve the overall outcome in the health system. I say thank you very much for, and I also extend my gratitude. I wish to extend my gratitude for the opportunity to present here, and my gratitude to the UNODC Office on Drug and Crime in Nigeria, the quality assurance team, and more importantly as well, Anais for the good training that she has given us, and then the assistance that we receive from her for conducting very good quality assurance assessment pilot in Kano State. Thank you.
Dr. Salihu, thank you for your presentation and for sharing your experience implementing these tools. And I think it's important that you noted this project was part of a project that was EU funded in a broad scope, specifically in Nigeria, using tools developed in quality assurance through INL contributions with UNODC, which I think provides a really great example of how UNODC is able to coordinate across multiple sources of funds to really collaborate and build these sets of tools. And again, it's really exciting that tomorrow UNODC will be launching the new document that is the result of collaboration across many, many agencies and organizations. So thank you for sharing your experience. So we will next turn to Dr. Jose Luis Vasquez Martinez, who is a demand reduction specialist at the Inter-American Drug Abuse Control Commission, or CICAD, at the Organization of American States. He is a Mexican physician who graduated from the Medicine School of the National Autonomous University of Mexico with a specialization in addiction treatment and a master's degree in comprehensive prevention of drug use from the University of Veracruzana. He has worked in a variety of capacities in drug demand reduction and will be joining us today now to share his experiences at CICAD. So Jose Luis, over to you.
Thank you so much, Alan. Hello, everyone. Good morning, good afternoon, or good evening, depending on how far you are from Greenwich. Thanks for joining us today. I am honored to participate in the INL Week as a presenter, representing the Inter-American Drug Abuse Control Commission, CICAD, of the Organization of American States. Thanks to Alan for the moderation of today's webinar. My appreciation goes to my good friend and colleague, Maria Virginia Garcia Mavi, who has been instrumental in tuning all the technical details. My presentation will focus on the importance of quality for treating substance use disorders in the Americas. As you know, globally, substance use disorders impose a heavy burden of disease, disability, and death, representing the loss of healthy life years, productivity and well-being, and high social costs, among other issues. The recently approved 2020 SICAD Hemispheric Drug Strategy states that the world drug problem constitutes a global challenge that negatively affects public health, security, human rights, the environment, and well-being. It also undermines sustainable development, justice systems, political and economical stability, and democratic institutions, representing a threat to security, democracy, good governance, and the rule of law. In the Americas, the drug problem is an increasingly complex, dynamic, and multicultural phenomenon that adversely affects multiple aspects of life. Responding to this problem requires a comprehensive, balanced, multidisciplinary, and evidence-based approach in full respect of human rights and fundamental freedoms under the common and shared responsibility principle, which considers the causes of the problem and includes demand reduction as a priority component. Demand reduction policies include as essential elements universal, selective, and indicated prevention, environmental prevention, health promotion, early intervention, treatment care, rehabilitation, social integration, recovery, reducing adverse consequences, and related support services. Ideally, treatment services offer a range of comprehensive therapeutic intervention models that are evidence-based and follow internationally validated quality standards oriented toward treatment completion and sustained recovery. But what do we understand as treatment? Even though there has been a definition by the World Health Organization, WHO, since 1996, it is not widespread. The WHO defines treatment as the process that begins when psychoactive substance users contact a health provider or other community service and may continue through a succession of specific interventions until the person reaches the highest attainable level of health and well-being. Treatment models must consider the needs of different populations, taking into account factors such as gender, age, socioeconomic context, community, culture, and other social determinants of health. These considerations are crucial from a gender perspective. As you can see on the screen, according to the 2018 World Drug Report by UNODC, more men than women initiate drug use, but after initiation, women move faster than men towards drug use disorders. This phenomenon is known as telescoping and should define how to address specific treatment needs for substance use disorders within communities. Although substance use is nowadays a significant cause of disability globally, few studies estimate treatment coverage cross-nationally. An analysis of data published in 2017 from the World Mental Health Surveys found that among 70,880 participants, 2.6 met the 12-month criteria for substance use disorders. Of those affected by substance use disorders, 39.1 recognized a treatment need. Overall, only 7.1% of those with past year substance use disorders received minimally adequate treatment, which means 4 sessions by professionals or 6 sessions by non-medically trained professionals. These data suggests that only a minority of people with substance use disorders receive even minimally adequate treatment. At least 3 barriers are involved: awareness, perceived treatment need, accessing treatment once a need is recognized, and compliance to obtain adequate treatment. According to the World Drug Report 2021, only 1 in 8 people with drug use disorders receive treatment each year. Cannabis use disorders are a significant source of treatment demands, and a lot of other details, epidemiological details that you can consult in this report. And there is still a significant gap in national capacities in many countries to provide evidence-based services as a public health system. The 2021 World Drug Report findings reinforce what we found in our study, the drug problem in the Americas, which identified that treatment systems rely on a fragmented and segmented network with limited professionals. Additionally, the integration of treatment services for substance use disorders, at least in the Americas, requires investment and specialized training. As many of you witness, current hemispheric challenges correspond to our study's findings, which the COVID-19 pandemic has intensified, such as crowded treatment centers, inadequate facilities and services, among many others. To address this complex situation, and because countries of the Americas define and apply in different ways the standards to allow the treatment centers for people with problematic drug use to begin and continue operations, CICAD, jointly with PAHO, the Pan American Health Organization, developed the indispensable criteria for treatment centers, which of course are complementary to the basic and advanced criteria produced by COPOLAT, in which we also contributed. And these criteria are arranged in several categories that you can later explore in detail by checking our document of all these quality criteria that we use currently for supervising treatment facilities, programs, and centers. And as Anya mentioned, we have conducted some mapping initiatives, mapping projects from December 2020 to March 2021. CICAD updated this report, the 2011 Directory of Caribbean Drug Prevention, Treatment, Rehabilitation, and Gang and Youth Violence Focused Institutions. The 2021-2020 assessment comprises 117 verified responses from agencies across the Caribbean region, further than the 2011 sample. This mapping is the foundation for rolling over quality assurance mechanisms in the Caribbean, and similar processes in other sub-regions of the Americas should follow. From CICAD, we will be delighted to continue contributing to processes such as the one led by UNODC, which seek to attain the highest performance levels by services, programs, centers, and professionals to achieve health and well-being for our member states' population. Thanks to our partners and allies with whom we walk along the quality assurance path. I appreciate your attention in today's webinar and turn back to Alan to continue. Thanks.
Thank you very much for your presentation, for sharing the ways in which CICAD has participated in this process and in fact has helped convene many of the stakeholders and has been a true leader in this process. So thank you for your presentation and for the participation of CICAD. So next and finally, we will turn to Nancy Paul to present. And she is the CEO of STAR Rhode Island, a nonprofit treatment organization, and she has been for the past 35 years. She is a licensed alcohol and drug counselor, holds a Master of Science in Applied Business Management, and was a founding member of the Network for the Improvement of Addiction Treatment, a quality management programming focusing on access and retention in care. Nancy will share with us today perspectives from the private treatment center perspective and the ways in which private centers can be involved in a process like this as well. So Nancy, over to you.
Thank you. are you going to share my slides? Or should I?
If you want us to share
Yes,
it,
would you please?
sure,
Thank you.
there you go.
Thank
You
you
just
so
tell
much.
me next one and I will click on this on the screen.
Yeah, it should, thank you. So I'm happy to be here to present the community perspective of a private nonprofit treatment agency located in Fall River, Mass. You can switch. We started out in 1977 as a 20-bed inpatient detoxification program. And today, STAR is really a system of care with integrated primary care, behavioral health, outreach, all the things on the pyramid that Anya was talking about. Pretty much STAR does provide that. We currently have 500 employees and $37 million of revenue in 2021. Okay. Switch. We've not only expanded in size, and size has never been the thing that I've been excited about, but it's been so important for me and for my life's work to develop quality programming. And before COVID, organizations across the US and throughout the world came to STAR to learn about our innovative programs and how we provide services. And even our local state government, the state of Massachusetts, is now redesigning its behavioral health system, somewhat based on STAR's system of care and our access programs. Okay, switch. So how does an organization from a small city of about 87,000 become so well known? And I really truly believe that's in large part due to the focus on quality improvement, which has been incorporated into everything we do. Okay. So the purpose of our quality improvement program is to systematically monitor and evaluate the provision of the healthcare services we provide and what the impact of these services are on improved outcomes for our patients. Okay. So the goals of our program are to promote recovery and resiliency to support improved healthcare outcomes. We want to have improved client and provider satisfaction with services, because if your providers aren't satisfied with the way things are done, I doubt your clients will be getting good care. So we not only look at our clients, but our service providers. And what we do is we produce actionable, valid, and reliable data to drive all our decision-making, resulting in improved client care. Okay. I think it's, as we say, no one treatment program fits everybody. No one set of quality metrics fits every program. So each program has their own set of quality metrics that we measure. In addition to our metrics based on standards of care, we are looking at the metrics of the people that fund us. And we get funding from the US federal government, from our state government, from third-party insurances and private foundations. And I think it's important that in your quality activities, people at all levels of care are involved in the process, not just your management team, your leadership. It's important to have line staff, mid-level managers, and when we're looking to make changes, we always include some participants of care. And this is based on the Network for Improvement of Addiction Treatment Change project model that we were a founding member of. Okay. So the overall examples of quality performance metrics: access and availability, quality care of clinical, quality of clinical care, safety and risk management. And this is, we meet every month to look at what's not going well. Okay, turn. We also look at member satisfaction, our patient satisfaction, our provider satisfaction, and other satisfaction surveys. We also look at screening, Because as I said, we are a system of care. And so no matter what door you walk in, Star, I want to know that you have had depression screening, ADH screening, substance abuse screening, so that we can see what the picture is for the whole person. And there are some very easy tools that will give you some indication of where you should go. Okay. So here are some of our quality reports, and I'm starting at very basics. We look at, for access purposes, the number of calls that come in every week and how they are handled. In 1 week, we had 1,254 calls. We know that 942 of those calls were handled by live people. People were put in queues for 37 seconds. And even though they were in the queue for that amount of time, we lost 18.9 or almost 19%. So we know that we lost them at 38 seconds. So what we try to do is look every week to see if we can bring down the time people are queued and try to get more people answers in a faster period. Okay, move on. Here's a state QI data metrics of our opioid triage center. And this is a walk-in center for anyone with an opioid problem. You don't need an appointment, you don't need to call, you just walk in. And from the period from 2017 to the 21, we had almost 13,000 enrollments, which represent about 7,000 patients, unique patients. The goal of this program is to assess them and get them into care quickly. And our length of stay, 84%, almost 85% of our patients had a referral within 1 day of coming in. And 15.4% had a referral within 2 days. I can tell you how many men and women, I can tell you the race, I can tell you how old they were, and I can look at, from this data, what the top problems of our enrollees are, so that we can develop programs. I was surprised when this data first came out that so many of our enrollees were homeless, over 20%. And we also look at how many people, because we have such a huge opiate problem, how many people we can get into medication-assisted treatment. We also look at where we refer them to. The biggest one was to detox, outpatient, methadone, mental health services, etc. So we have a great idea of who's coming in, what their needs are, and what we need to do to help them. Okay, please move. Switch the screen. This is an insurance company's quality report. And if you look down at the bottom, one of the things they point out was the average length of stay in our detox program was almost a day longer than other providers. So they were not happy about that. However, what you see at the bottom one was that for those people, we had a much higher rate of people getting to the next step of care compared to our other providers in the state of Massachusetts. So although we kept them a day longer, we were able to exceed the expectations of getting people into the next level of care. And we know that for the next level of care, that improves the quality and the outcomes. Okay, can we switch? Because I know we're about out of time. This was a screening project we did in the city of Fall River with a SAMHSA grant. Our goal was to screen 5% of the population, and to cut to the chase, we screened 6.3% of the population at different places. We learned at the bottom circle graph that 51% of the people had no or minimal risk, 23% needed a brief intervention, and 26% of the people we screened needed higher level of care. And so this was a really important project. Okay, can we move on? And we were able to demonstrate that we were successful in getting people into care. This is a minutes of a risk management meeting we had. We look at the things that are not doing well, and we meet to plan on what to do. Okay, move it forward. So here's a private foundation who was interested in getting some data from 4 substance abuse agencies in Massachusetts that had a certain amount of funding. And STAR here is represented as Site 3. And what we were able to show was, because of the work that we do at STAR, we were the only one of the 4 agencies that was able to improve mental health functioning from baseline to 12 months. And then the other next slide, we showed that we had a significant decrease in, next slide, anxiety between pre and post tests. So something we're doing is working well. Next slide. We also look at data to help us create new programs. And here is our methadone program. And we heard that people were complaining that they were hungry. They usually come in first thing in the morning, and we heard hunger. So we had people screen, and we worked with a local food bank in Boston. And this is what we found. 59% of our people were food insecure. They did not have enough food. So what did we do when we learned about this? You can't deal with treatment if you're hungry. So we started a food bank and a distribution, and in our parking lot, certain days of the month, we provide food for our patients. Okay. So quality improvement at STAR. It shows us what is working well and what is not. It gives us a chance to improve or create services in order to meet the needs of the people we serve. By meeting their needs and understanding their needs, client satisfaction improves, treatment improves, our overall agency functioning improves, and staff become happier in their employment. As I have shown you, data informs much of what we do and how we change. And government, private funders do look at the data, and they are more likely to continue to fund us or fund new projects if they can see outcomes. Move forward. I know this was a rush, but I was the last one. I'm happy to take questions either today or in the future. There's my email. Feel free to email me. Thank you very much.
Nancy, thank you very much for your presentation and sharing your perspectives and insights on the importance of continuously evaluating quality, finding ways to improve even in centers that are already providing care at a high level of excellence. I think your discussion of the call time was very striking to me, because even in a center such as yours, where you're able to answer the phone in under a minute, you're losing nearly 1 in 5 people who are seeking assistance. And I think it's very important you raise this to the group, that your center is constantly looking at this kind of data, evaluating where the gaps are, and trying to find ways to close those gaps to reach more people in need. And so I think this is a very concrete example that really drives home the importance of this consistent attempt at quality improvement. So I know we're a little over time, but we will still try to answer a couple of the questions in the chat box before closing out our session today. I thank all of the panelists who have already answered many questions in the chat box in the chat by text. I will first ask Brian Morales to address the question on universities.
Thank you very much, Alan. Yes, on universities, there is the International Consortium of Universities for Drug Demand Reduction, and I invite everyone to check out their website, which we can put in the chat, icuddr.org. This is a consortium that promotes academic programs in addiction studies and also has a focus on quality through their International Technology Transfer Centers, which are a a new network that is being built in many countries around the world to take a systems approach and to improve quality as well. Thank you, Alan.
Thank you, Brian. I know there have also been some questions regarding compulsory and voluntary participation in treatment, and that Annette has answered a component of this in the chat box. I would also invite Anya to share some thoughts from her perspective as well.
Thanks so much, Alan, and thanks for the questions. I mean, maybe to say that as a beginning, as we've said, drug use disorders are health disorders, and therefore, like for any other disorder, there needs to be informed consent for any medical intervention, for any treatment, right? So that's the principle. Now, I think the NIDA principles say that treatment does not need to be voluntary to be effective. But what is meant with that is that even if you're sent by the court, or if your husband or wife says, I will divorce you if you do not go to treatment, right? So there is a bit of push. You can still, when you get in contact with the treatment service, no matter how you got there, kind of build the motivation for treatment. So that is meant, right? Even if it was not your decision on the Sunday morning to seek treatment, but there was a bit of pressure on you to seek treatment, treatment can still be effective. That is very different from when we speak about detention centers that have a name of treatment center, right? So those centers are kind of very often kind of places where human rights abuses take place, and UNODC and partner agencies have repeatedly called for the close of those and for the kind of development of treatment services and systems based on evidence in the community. And just to say, in 2009, we had already launched a discussion paper with a slogan, which I still think is beautiful. It's called From Coercion to Cohesion, which speaks to the fact that if we offer, remember the principle, attractive drug treatment services, maybe like the one Nancy just presented, where people would really like to go, then there is also no need, so to say, for coercion, but we have a cohesive kind of relationship between service provider and patient. So I think that's what I can maybe add to that.
Thank you, Anya. I also see a question about the process after treatment, or what we would consider recovery. Now, while today's session focused specifically on treatment and on improving quality in treatment, recovery is itself a topic where we could do an entire webinar. So I don't think we'll go too far into this question today, given the time, but just a short answer saying, yes, there are many resources on developing recovery programs, and all of the organizations that are represented here today would be able to provide further guidance after the session. So with all of these comments and questions, I think we can now formally close the session. So first, let me thank all of the panelists for joining today. This has really been an information-packed session, but also I think quite interactive. And so I thank you for your presentations. I hope that for all of the participants, this helped provide background on the foundational documents, on treatment standards, and the quality assurance tools that have been derived from those standards, and some concrete experiences and examples of how these programs can work in practice. Finally, I would like to thank CCAD for hosting and providing the technical support through their Zoom platform, and to Maria for providing the interpretation to enable a much wider audience to join. Finally, resources will be posted on the U.S. Department of State website, along with the recording from today's session. Finally, there are 2 more sessions as part of our Webinar Week series. Tomorrow will be a session on drug sales over the internet, and on Friday will be a session titled The Drug Trade and Illicit Finance. So we invite you to join those sessions as well. So thank you again for your participation today, and have a great morning, afternoon, or evening, wherever it is you may be. Bye, everyone.
Thank you. Thanks everyone for joining us.